guys. Thanks for tuning in on a late, I think it was Wednesday night on a cold winter's night. So hopefully we'll discuss some new things that if some of you have tuned into some of my other webinars that we haven't discussed before. We just want to go over some of the atypical disorders that we can actually treat with shockwave therapy that maybe some of you are not aware of. Now, some of these conditions I haven't treated myself, such as erectile dysfunction and Peyronie's disease, but I have spoken with one of our clinicians, Dr. Rob King, who works here in Sydney. He's a general practitioner who does treat those conditions, and he gave me some insight into their treatment. And if you guys want any specific answers to any questions, if you want to write them into us regarding those conditions, we can look up some answers for you, but I might not have too many answers for those specific subjects. So again, we just want to go over some of these atypical disorders. The ones we're going to cover tonight are spasticity, erectile dysfunction, Peyronie's disease, and Dupuytren's disease. So let's first start with spasticity. So spasticity is defined as a velocity-dependent increase in muscle tone with exaggerated tendon reflexes. It's a symptom of central nervous system dysfunction related to an upper motor neuron syndrome. Other symptoms include jerking, twisting, involuntary contraction of the limbs, which are called dystonia, and they can all accompany spasticity. Spasticity can lead to permanent contracture, resulting in immobilized joints and even greater disabilities, such as equinovarus deformity in the lower limb. Several studies report that chronic spasticity itself plays a role in the increase of joint resistance by structural and mechanical changes to the skeletal muscles through fibrosis. So a big part of what occurs with spasticity is they get fibrosis of the connective tissue, and when left for long periods, years, it tends to harden and get a bit worse. So if we can get in there with patients at an early stage of this condition, we can have greater effects. So just going to go over some stats. The prevalence of lower limb spasticity is estimated to be about 28 to 37% for people who suffer stroke, 41 to 69% in people with multiple sclerosis, 19 to 92% in cerebral palsy, and approximately 13% with traumatic brain injuries. So there's quite a few conditions there that have spasticity as a symptom. So there's quite a number of people that we can help with this if we can treat this condition. So here are those conditions again. There's also Parkinson's disease, which I didn't include in the other list there. So chronic spasticity itself is believed to play a role in the increase of joint. We already talked about that. So that's the fibrosis, again, with the connective tissue. So we want to address that predominantly with our shockwave therapy treatment. So common medical treatments for spasticity currently, a lot of them are treated with chemical nerve blocks and motor point blocks via intramuscular injections. So Botox, botulinum toxin type A, phenol, and ethyl alcohols. They also use oral anti-spasticity drugs listed here. And you can also have intrathecal baclofen pump. And also there's more invasive procedures such as surgical interventions. So if we can avoid some of these more invasive procedures like surgery by using shockwave therapy, then I think it's a lot safer for one, and more cost effective, and if it's a lot a lot more people, I think, would opt for shockwave therapy over surgery if they can. So just going over Botox treatments, botulinum type A. So there are a few pros and cons for the treatment of spasticity. So the pros are the benefits usually felt immediately after the first treatment. It reduces spasticity and hypertonic muscles of the upper and lower limb and improves functional abilities. One injection can provide pain relief and lasts up to 3 to 4 months. And the treatments are readily available in most medical clinics. The cons are injections are somewhat painful. Often you need a radiologist or sports med to inject them, or someone who has specialty training. The dosage, you have to get the dosage right to treat severe spasticity. And again, it can be relatively expensive, between $200 to $1,000 per injection, because there's about 3 injections are generally required. And there's a risk of infection, and patients require ongoing treatment, as we said, because the effects only last 3 to 4 months. So the mechanism of action, so we're talking about, here we're talking about shockwave. So with shockwave, the mechanisms of action are, it induces nitric oxide synthesis. It has acting on fibrosis of the chronic hypertonic muscles, and also has mechanical vibration stimulation. So there's not a clear consensus on which of the 3 is the most prevalent, but they believe all of them play a part in how we get clinical effects with shockwave. So the pros for shockwave is we get anti-spastic effects can be observed for 4 to 12 weeks after treatment. Immediate therapeutic effect of shockwave therapy in reducing spasticity even after just 1 treatment. There's virtually no adverse events with shockwave therapy. It's a non-invasive procedure. The treatment is only mildly painful, and it's relatively inexpensive. Most clinics charge $70 to $200 inclusive of the shockwave, compared to Botox, which is about $200 to $500 per treatment. Cons is shockwave therapy is not always available in all allied health clinics, and usually requires about 4 treatments to get a good lasting effect. So we're going to talk about erectile dysfunction now. So erectile dysfunction is defined as a persistent inability to obtain and maintain an erection sufficient to permit satisfactory sexual performance. It can affect both physical and psychosocial health, and can have significant impact on the quality of life of sufferers and their partners. So there's different stats going around, but it usually says about 30 to 65% of men over age 40. A few other stats I saw was it kind of matches the age group. So about 40% of men over 40, 50% of men over 50, and about 60% of men over 60 suffer from ED, which is they're pretty high numbers if you think of it in that kind of perspective. ED is recognized as an indicator of endothelial dysfunction and may precede a coronary incident by 1 to 3 years. So it's important to see it as an indicator of other comorbidities. And when I was talking to Dr. Rob King, he was saying he always sends all his ED patients in for a full workup, heart workup before he treats them to rule out any other problems with their hearts. Most prescribed medical treatment includes phosphodiesterase 5, which is the short term to PDE5 inhibitors. So that's your drugs like your Cialis and Viagra, or you have the intracavernosal injection therapy. So that's a direct injection into the penis itself. How are we going, Danny? Everything coming through all right?
Sounds perfect. Looks great.
Not going too fast?
Great speed.
Okay, all right. Hopefully we'll probably get done a little bit quicker. So again, the mechanism of action. So it's not fully understood, but the hypothesis is that we get stimulation of neoangiogenesis. So we get the new formation of blood vessels. And as we know with ED, that's one of the main things. It's a lack of blood flow to the male sexual organ. So if we can increase the number and the function of the blood vessels in the penis, then that's going to have a significant effect on this condition. They also believe that we get recruitment of stem cells and Schwann cell activation, leading to nerve regeneration. So the positive effect of low intensity shockwave therapy on the cavernosal function seem to be the result of enhanced nitric oxide. So that causes, again, the nitric oxide is what causes the angiogenesis in the body. And it turns on cyclic guanosine monophosphate production by activation and upregulation of endothelial nitric oxide synthase and neuronal nitric oxide synthase. That's hard to say fast. Okay, so we get increased expression of vasoactive endothelial growth factor and has been observed in nearly all experimental shockwave studies. So we get the endothelial growth factor, which gets proliferated through shockwave therapy as well. So obviously contraindications for using shockwave for this condition would be local abscesses, bleeding disorders, patients on anticoagulant medication, and acute infections. So again, here we go with the common medical treatments for erectile dysfunction. So we just talked about the PDE5 inhibitors such as Viagra, Cialis, and Levitra. We also have the intracavernosal injection therapy. So that's they inject alprostadil directly into the penis. Dr. Rob King was saying for some people, not all people with patients with ED respond to the PDE5 inhibitors. So for those who don't, they tend to get put onto these intracavernosal injections because they tend to work for those people that don't get the effect with the PDE5s. And he was saying even some people who use the PDE5s that before they were around, I think they came out in 1998. He said the ones that used it before then, they were just comfortable using the injections and they just kept on using them instead. You can also get surgical interventions, so that you can get penile implants that help with this condition as well. So the PDE5 inhibitors enhance the effect of nitric oxide, a natural chemical your body produces that relaxes muscles in the penis. This increases the blood flow and allows the males to get an erection in response to sexual stimulation. Oral erectile dysfunction medications are not aphrodisiacs and will not cause excitement and are not required in males who can achieve normal erection. So you still need, even though it allows better blood flow to the penis, you still need some sexual arousal for it to get an erection. Some side effects people get from PDE5s is flushing, nasal congestion, headaches, visual changes, backache, stomach upset. So you need to work with your doctor to find the right medication and dosage. Again, Dr. Rob King was saying dosage is important, both for the PDE5, but also for the the intracavernosal injections. Because if too much is injected, it can actually be painful because the erection kind of gets too and engorged, and it can be painful, or the erection can last for hours if the dosage is wrong. So he says he always has to work with patients, and he always starts with a low dose, and then when they go home on the drug or injection, they have to kind of slowly increase it until they reach a point where they have a good result, or back off if they've gone too high. So it's something that he works closely with his patients with, and he advises them that, you know, you can't overdo it. So it's, again, a lot of people think more is better, but in the case of drugs, it can be harmful. So the pros and cons for PDE5 inhibitors. Let's turn that. I just had my Shockwave compressor go off, so I turned it off. So going back to the pros and cons here, pros are low risk of adverse events. It's highly effective. It's a non-invasive procedure, and they're fast acting. Usually you can get an erection within 30 minutes of taking a PDE5, and the treatment's not painful. Cons is that you can get side effects as we listed above on a previous slide. The patient can become reliant on the meds. It still requires sexual stimulation to work. Again, you need to work with your doctor to find the right medication and the right dosage. And for some people, the cost can be prohibitive. The Cialis is a bit cheaper. It costs about $1 per tablet, and they're not currently on the PBS. It's also contraindicated for individuals who have hypotension, because it can actually be fatal if their blood pressure drops too much, or if they have heart disease or heart failure, and patients on nitrate drugs. So comparing it to shockwave therapy for erectile dysfunction, there's virtually no risk of adverse events. It's a non-invasive procedure. Treatment is only mildly painful, and it's, again, relatively inexpensive, $70 to $200 per treatment. Cons is shockwave's not always readily available, and it requires at least 4 treatments, and the effects last about 3 to 4 months. So some objective questionnaires that they use to measure erectile dysfunction, two of the most commonly used are the International Index for Erectile Function and the Erectile Hardness Scale. So I just want to make you aware of that, because I'm just going to go through some of the literature where they talk about these scores. So just looking at a systematic review by Fojeki in 2017, which included 4 RCTs with 337 patients. The one RCT by Vardy and Srini showed a clinical significant effect of shockwave therapy on the International International Index of Erectile Function and the Erectile Hardness Scale. The Vardy et al. Trial had 19 of 28 men, about 68% in the treated group, who were initially unable to achieve erections hard enough for penetration. So that's erectile hardness scale of 2 or less. Were able to achieve erection sufficiently firm to achieve penetration. So that's an EHS3 or greater after shockwave therapy, compared to none in the sham group. So the sham group, usually what they do is they just turn down the shockwave to virtually nothing. So it makes a sound, but it doesn't put really any energy into the penis. So in this case, they had, with the sham group, they had no change whatsoever. In the Srini et al. Study, 71% of treated men achieved an EHS of 3 or greater. One of the other RCTs reported positive effects in EHS scale, but no significant improvement in the IIEF score. And the last RCT, Yi et al., were both negative with regard to the two scores. However, they reported significant positive effect in patients with severe ED. All right. So we'll talk about Peyronie's disease now. So Peyronie's disease is a non-cancerous condition resulting in fibrous scar tissue that develops within the penis and causes a painful curvature, usually felt more so with erections. However, it can be felt when the patient is flaccid. So Peyronie's disease is characterized by an initial acute painful inflammatory phase followed by a chronic stage where the plaque stabilizes. So they usually get formation of hard plaques within the penis that they're also hard when the penis is flaccid and can be painful. It is usually caused by repeated penile injury, typically during sex or physical activity. And in some cases, with lack of compacted calcified plaque, there is potential of a deviation of the deviation to diminish, so the curvature. In other cases, it may even progress. So the stats, there's different stats, obviously, but a common one was about 4 to 8%. I saw a few that went up to about 20%. When I spoke to Dr. Rob King, he indicated that he thought it was about 10% from his clinical experience, at least 10% of the male population, which is again a significant proportion of the population that are suffering from this condition. The incidence increases with age, so it peaks in the fifth decade of life, and one study showed a spontaneous improvement was observed in about 12% of patients without any treatment, stabilization in 67%, meaning it didn't get any better or worse, and a worsening of symptoms in about 21% of patients. So a physical exam is also often sufficient to identify the presence of scar tissue in the penis and diagnose Peyronie's disease. However, some clinicians might order an ultrasound or do a Doppler to examine the blood flow to the penis and get a more conclusive diagnosis. So similar to ED, the mechanism of action is we get positive effects of shockwave therapy on the cavernosal function, seem to be the result of enhanced the nitric oxide in turn cyclic guanosine monophosphate production by stimulation and upregulation of endothelial nitric oxide synthase. So we get treatment with shockwave therapy has been shown to increase cavernosal smooth muscle collagen ratio, increasing elastin fibers, and down regulates the transforming growth factor, beta 1, connective tissue growth factor signaling pathway, which can stimulate antifibrotic tissue remodeling. So that's basically a fancy way of saying it increases the collagen and elastin fibers in the penis, and it also downregulates some of these growth factors. So contraindications, again, similar to ED, is local abscesses, bleeding disorders, patients on anticoagulant medication, and acute infections. Common medical treatments for Peyronie's is oral medications, traction and or vacuum devices, radiation therapy, intralesional injections, so they inject right into the plaque, and surgical interventions. And that's usually only used for really severe cases. So pros and cons of shockwave therapy for Peyronie's. Again, there's virtually no risk of adverse events in the literature. No non-invasive procedure. Treatment is only mildly painful. It's relatively inexpensive. The cons are, again, that shockwave is not readily available everywhere, and it requires at least four treatments. Dr. King said he usually does 6 treatments. So here's some anecdotal evidence from Dr. King. He said that smaller plaques respond much better to shockwave therapy. I didn't finish there. That sentence there. So larger plaques don't respond nearly as well. He tends to find the larger the plaque, he said it's almost impossible to change. You can also combine. He combines the shockwave with either the use of a vacuum pump or a penile stretching device. Now he also told me about this wonderful program that they have. It's called Men's Health Down Under. I didn't have the website here, but we can share that after. Danny, can you put a note to get the website for that, please?
No worries, all good.
Yeah, Men's Health Down Under. So it's a Zoom service that teaches patients how to properly use the vacuum pumps or penile stretching devices, so that they, obviously, like anything, if you don't use it properly, you won't get the effect. And it was started up by a pharmacist named Brad Butt. So Dr. King uses his settings he uses when treating Peyronie's. He uses about 2 bar pressure, 14 hertz. He uses the 15 millimeter applicator, about 2,000 impulses per area of the penis, and he said he usually works about 4 different areas to give a total of 8,000 impulses for the session. He likes to do about 6 sessions at a once a week intervals, and then he reviews the effects after about 3 months. And if their results are positive, then he'll do another 6 sessions with them. With the ones that don't get a result, he'll usually advise them that the treatment's probably not going to result in any benefits for them, and they'll seek out some other form of treatment. Literature review. So systematic review by Fojeki again. 2017, which had 3 RCTs. The RCT by Paul Miri in 2009 had 100 patients, which involved 4 weekly shockwave treatments with a 24-week follow-up. The settings were the EFD, which is another way of measuring the bar pressure, was 0.25 millijoules per millimeter squared, 4 hertz, and 2,000 pulses. At 24 weeks, the mean plaque size and curvature were significantly higher in the sham-treated group when compared to both baseline and shockwave values, meaning basically the sham group had no change, while the intervention group had a change with the shockwave therapy. The 2 other RCTs showed no change in the plaque size or penile curvature. However, both recorded decreased pain or on the visual analog scale. So the one study, RCT by Hatzichristodoulou, 2013, demonstrated a decrease in visual analog scale of 85% of patients in the shockwave group, while only 48% had a decrease in visual analog scale in the sham group. So again, significant difference in the numbers there. However, of concern was that 5% of patients in the shockwave group had an increase in the size of the plaque. I discussed this with Dr. Rob King, and he said that's just a common occurrence with the natural history of the condition. So he said most of those patients, that probably would have happened anyway, regardless of whether they had shockwave therapy. He said he hasn't seen anything that showed any causation between shockwave therapy and the increase in the size of the plaque. So yeah, so basically that might have been an incidental kind of finding. So the RCT by Chital in 2010 demonstrated a decrease in the visual analog scale. I didn't write down the percentage there that she had. Unfortunately, I'll put that in the notes after if you guys want to see the numbers that she had. So again, with shockwave therapy, there's no adverse effects. That's one of the beauties of the therapy for these conditions is all the literature shows that there's no adverse events. So worst case scenario for most of these people is that that they'll have no change. Whereas if you're getting injections or you're doing oral medication, or if you're going and worst case scenario having had surgery, there's loads of adverse effects that can happen with those interventions. So I think that's a big plus for shockwave therapy is that there's no adverse events and that we've seen in the literature. So again, contraindications for Peyronie's would be treatment over local abscesses, bleeding disorders, patients on anticoagulants, acute infection, or if the patient. So again, with the Peyronie's, it can be painful. So sometimes some of them might get cortisone injections. You can't treat those people for 6 weeks after they've had the cortisone. Let's talk about Dupuytren's. How are we going there, Danny? Any questions or anything?
There's one question, but I think we can save that to the end. It's currently 8:33, so you're all fine on time.
Okay, all right. So we're getting to the end, so we'll probably end a little early tonight, which I think might be good for some people. They can go have a drink or finish their dinner. But let's talk about Dupuytren's disease. So Dupuytren's is a progressive fibromatosis of the palm and flexor side of the hand, leading to digital contracture. It usually develops over many years and commonly occurs in older men of Northern European origins. Histology has shown increased but varying levels of particular types of collagen, myofibroblasts, and myoglobin proteins in Dupuytren tissue. And Dupuytren disease often causes permanent flexion contracture of the metacarpophalangeal and proximal interphalangeal joints of the digits, leading to loss of function, deformity of the hand, and permanent contracture of the involved digits. So Dupuytren's contracture can occur in both hands, but it usually affects one more severely than the other. And there's a high rate of recurrence even after surgical intervention, and can often require amputation of the affected digits. So even after people have surgery, it can still come back. So they basically separate into a few stages. We've got 3 stages: proliferative, and involution, and residual. So you can see on the picture here, they usually form a small nodule and around the crease of the hand here. And then in stage B, they get the formation of a cord. And stage C, it's a contracture of that cord, and usually pulls in the little finger with it. So with Dupuytren's is associated with the abundance of collagen, fibronectin, integrins, cytokines, and many other growth factors, as well as altered expression of several genes. So it's a multifactorial condition. So you have multiple changes that are occurring to the tissues that cause the changes. So doctors don't know what the actual cause is. There's no evidence that hand injuries or occupations that involve vibrations lead to the cause of the condition. There are some risk factors, though: alcoholism, smoking, thyroid problems, liver disease, diabetes, previous hand trauma, epilepsy, can be due to a risk factor can be anticonvulsive medications, and certain genetic predisposing factors such as autosomal dominant variable penetrance. So one study let's skip that one, that I looked at was this study done by Knobloch. Focused electromagnetic high energy extracorporeal shockwave reduces pain levels in the nodular state of Dupuytren's disease. So in this study, they had 52 patients. Mean age was 58 plus or minus 9 years. With painful nodular Dupuytren disease divided into 2 groups. They had 3 sessions of focused electromagnetic high energetic shockwave therapy was the one group. And the placebo group, again, what they did was they just turned down the shockwave device to 0.01 millijoules per millimeter squared. So it basically was almost off. It just makes a sound. So it does virtually nothing. The major finding of this RCT was that shockwave is an effective and safe non-invasive treatment to reduce the pain in early nodular stage of Dupuytren's disease. And 3 focused shockwave sessions could demonstrate a significant pain reduction and sustained effect over 18 months of follow-up in this RCT. Another one I included here was with radial shockwave therapy. It was just a case study. The intervention was 4 weekly sessions of radial shockwave therapy, 1,400 impulses, 3 bar at 12 hertz frequency. This case report demonstrates the feasibility of shockwave therapy, radial shockwave therapy. Sessions may be carried out by, should be any allied health professional who has proper training in how to use shockwave. And outpatient clinics with cost reduction compared to surgical treatment and focused shockwave therapy. Radial shockwave therapy is a non-invasive, well-tolerated therapy and should be considered in the treatment of Dupuytren's disease. Just some other atypical conditions that respond as well to shockwave therapy. I didn't have time to obviously go through all of them tonight, but non-union fractures, as well as stress fractures, Lederhose's disease, which is similar to Dupuytren's, but it just happens in the foot. Adhesive capsulitis, soft tissue wounds, we can treat with shockwave therapy. Primary and secondary lymphedema and scar tissue formation. I have a little experience with scar tissue formation. I used to work at a hospital for an orthopedic surgeon, and I would work on some of the scars, surgical scars after treatment with the shockwave device, and it made a noticeable difference in the hardness and flexibility of the scar tissue, and patients really noticed changes soon after just a couple of treatments with shockwave on those scars. So providers, one's me. Obviously, I don't do the Peyronie's or erectile dysfunction, but I have treated a patient with Dupuytren's. I had a decent result with him. We went from having his hand was totally flexed and contracture to I was able to get him to basically straighten his fingers out to about that position after about I think I had about 10 sessions with him. So he was pretty happy with the result. We got some more function into his hand and a little less pain. Also, just wanted to thank Dr. Rob King for talking with me and giving me that anecdotal evidence that I presented earlier. If you guys want to check out his website, it's robking.com.au, and yeah, so he does treat erectile dysfunction and Peyronie's disease if you guys want to refer. but he's in Sydney, obviously, so he'll be restricted to New South Wales for that. And also Marcus Sabella, he's a physiotherapist in Roseville. His website's there as well. He does some erectile dysfunction treatment, as well as the not Peyronie's, but Dupuytren's and spasticity.